Hello and welcome everyone to Oral Pathology Tuesdays on Oral Pathology 360. I'm Dr. Manana Donahue and I'm delighted you are here for today's session. Today we will be exploring an important and practical topic, oral mucosal lesions. But before that, a few housekeeping announcements. First and foremost, if you're watching the program from anywhere else but YouTube, you can head over to YouTube so that you will be able to interact with us through the live chat. Otherwise, you can, of course, watch it from anywhere. Another thing is if you adjust the settings gear and switch to 72p or higher quality, you will get a better quality of slides and they will be better to see. And of course, we have certificates enabled for our members to be able to get a certificate. If you are not already a member, click the join button, which is underneath the video as you're watching. Or if you're already a member, then all you need to do is just stay with us during the live stream. A link to the form has already been shared in the posts of the channel. You'll probably have also got it in an email from YouTube. And all you need to do is be with us, interact with us, and then fill the form, and you will get your certificate. Also, we have two new members, and great thanks to them. We welcome Dr. Kurian and Dr. Samira. Now, with that, let's move on to the lecture. It is my pleasure to welcome our speaker for today, Dr. Abhay Suresh Kulkarni, reader at MIDSR Dental College, Latur, and a PhD scholar at SDCH Pune. He is also the winner of the Faculty Open Mic competition and brings rich academic and research experience to today's session on oral mucosal lesions and overview. So, with that, let me just bring him in for a moment. Yes, hello, Dr. Abhay. You can say hi to everyone. Your mic is off, I think.
Yeah, good evening, all. Welcome.
Good evening. Right.
I
So, with
hope
that,
you all
as
will.
usual, sorry, please.
Yeah, I think all
Hello, your voice is breaking up, I think. Okay, let's go
the
watch
back.
the lecture as usual and we will come back. And
Okay,
hopefully,
so
by
it
then,
does.
Dr. Obey will have his sound worked out. Yes, let's watch the lecture and come back.
And welcome to this today's webinar. Uh, I'm thankful to the organizing committee for giving me the opportunity to share my the views on the topic, that is oral mucosal lesions. And this topic should have been actually a broad, like, rather overview of the oral mucosal lesion, because we are just going to cover a broad outlook of all the oral mucosal lesions. It itself is a big entity, and each entity will be probably a webinar. Coming to the topic, oral lesions can arise from a range of different etiologies: infective, idiopathic, inflammatory, reactive, and neoplastic changes. A clinician must obtain a thorough clinical history and have adequate knowledge of the signs and symptoms, such as the location of the oral mucosal lesions, its size, color, and morphology, to make a proper diagnosis. So, seeing a oral lesion and diagnosing a condition should have all these aspects, like what is the size, the color, before you actually come to a diagnosis. Oral mucosal lesions refer to the abnormalities or changes in the tissues that line the oral cavity. These lesions can vary in size, appearance, and location, and they may be associated with wide range of causes, including infections, inflammation, trauma, or neoplastic processes. Proper classification, accurate diagnosis, and effective management of oral mucosal lesions are essential for providing appropriate care and ensuring the positive patient outcomes. Broadway, it has got many ways to classify, but one of the simple ways that has been suggested by WHO is inflammatory, reactive, and neoplastic. Like, if you can just classify the lesion in out of these entities. The 2000 US Surgeons General's report, Oral Health in America, emphasized the strong link between oral health and overall well-being, highlighting the numerous ways in which oral and general health are interconnected. Like, now localized diagnosis, seeing oral lesions, diagnosing it properly, finding the signs, symptoms, location, the coverage of the area, that is not sufficient. Whether it has got some systemic link, that one should have always suspicion once the oral any oral mucosal lesion or oral changes even are has been diagnosed. A thorough oral examination can detect signs of various systemic diseases, including immunological disorders, endocrine and blood-related conditions, infections, and nutritional deficiencies, allowing for early diagnosis and treatment. Research has also shown significant connection between gum diseases and diabetes, heart diseases, stroke, pregnancy complications, understanding the importance of oral health in maintaining the overall health. So, oral mucosal changes, oral mucosal lesions should be viewed for overall health once it is been diagnosed or once you come across with these lesions. Some of the examples of oral manifestations, like if hematological disorders, anemia, pale mucosa, atrophic glossitis, ball tongue or angular chilitis, leukemia, gingival enlargement, spontaneous bleeding, and fatigue. Endocrine disorders, diabetes mellitus, increased risk of a periodontal disease, delayed healing, and oral candidiasis. Gastrointestinal diseases, Crohn's disease, cobblestone mucosa, deep linear ulcerations in the vestibule, ulcerative colitis, aphthous-like ulcerations, infectious diseases, HIV and AIDS, oral candidiasis, leukoplakia, Kaposi's sarcoma, and necrotizing ulcerative periodontitis. Then nutritional deficiencies, vitamin B12 deficiency, burning mouth, glossitis, and mucosal atrophy. All these diseases will come across the once we are doing examination, and we should be able to correlate it properly once we come across with these things. What is the clinical importance? Understand the nature of the disease, how it has occurred, and then you plan your treatment, and then find if any systemic correlation is there with that particular lesion. We'll see some of the normal variants. These are present: tongue, fisher tongue, caviar tongue, coated tongue, enlarged papillae, racial pigmentation, gingiva, physiological pigmentations, and retrocuspid papilla, buccal mucosa, stencils papilla, linea alba, leukoedema, frenal tag. The normal variants out of that, first is a Fordyce's granules. Like, these are the heterotopic collections of sebaceous glands which are present, and generally the manifestations there are the bilaterally they are present in the buccal mucosae, generally present bilaterally in the buccal mucosae. Now, if the number is high, we should have a suspicion of a risk of hyperlipidemia, and the concerned patient should be made aware regarding the same. That is the identity of oral physician or examining dental surgeon regarding the same. Caviar tongue, prominent lingual varicosities. This is common in old age, hypertension, cardiac problem, and rarely may bleed. So this is a common presentation, and probably the patient is coming for the tooth pain, and you just examine the tooth, take a radiograph, do the concerned treatment, and send the patient. If across some changes have come, ask the patient, take the patient's hypertension, take the patient's blood pressure, and see if the patient is hypertensive, and make aware regarding the same thing, that if it is not there, you are likely to get the proper physician's checkup done. Then fissure tongue, it may manifest from the small fissures, like superficial fissures, less in number, then deep fissures, and deep fissures are more in number, and probably having a may have a diffuse presentation. It has got some classification also, and this can be misdiagnosed or overtreated. And if it has been diffuse, the patient may have fear of something else, and we have to improve the hygiene of the patient, ask the patient to take care, and ask the patient to brush the tongue, clean the tongue, and improve the nutrition if it is possible. And if it is associated with syndrome, we may have a diffuse manifestation too. Transient lingual papillitis. This condition must have come across our clinical practice, but we have been neglecting it, or probably we have not understood it properly. Just minor burning, so we'll leave it like that. It's a painful inflammatory fungiform papillae onset in the childhood, progresses in the spots, and it is manifested by pain or discomfort. Although it is common, it is understudied condition, so we have to pay attention for this. And some of these are the manifestations of the transient lingual papillitis. And management is symptomatic and aims to relieve the symptoms. In painful cases, local anesthetics, topical corticosteroids, saline mouthwashes, and combination of antihistaminics with aluminum hydroxide or magnesium hydroxide suspension for topical use have been administered, and eating of a cold foods have been recommended. The use of analgesics such as paracetamol or ibuprofen does not affect the duration and intensity of the symptoms. Patients are also recommended to avoid the irritating chewing gums, and candies, or oral hygiene agents, other oral. Most approaches are achieved by the symptomatic relief. Some topical medication should be given once it is been diagnosed. Benign migratory glossitis, we are knowing this condition since we started studying our third year. And many of you just do come across this condition quite commonly in our clinical practice. This is a benign, may be symptomatic. Sometimes the patient may have a burning sensation, maybe rule out diabetes and a Reiter's syndrome. The condition is characterized by the atrophied papillae, and these are the sometimes large in number, and the patient may worried about the appearance, and the patient is supposed to we are supposed to assure the patient that it has got a benign nature, and just make the patient to give the follow-up for further follow-up for any changes. It may be associated with a fissure tongue. It should be treated with vitamin and nutritional supplements. If needed, sometimes we have to add antihistaminics too. Then this is a case which has been reported, and this is a fissure tongue, which an early leukoplakia lesion diagnosed before even the psoriasis cutaneous lesions were seen. So in rarities, we may come across with such kind of a conditions. So in what way they are linked with any systemic disease or having any dermatological correlation, that we should aware of. And at least in our dental average dental clinic setup, we are supposed to do the inquiry regarding these lesions. So the patient will be having the patient will be properly diagnosed, and then probably we can refer the patient to the concerned specialist. Now this is again interesting case. A 51-year male graduate reported to the periodontology department, where for the complete evaluation he was suffering from a bipolar disease, and then previously he was been diagnosed as a psoriasis, and the patient, the lesions were not there initially, and once the patient had come in the second time, then can you see some defined shape is there, that is serpentinous shape is there, and then the intraoral psoriasis diagnosis was made, and punch biopsy was done, and then the further treatment is been instituted. Further patient is advised for the further treatment. Rarely we do come across with such condition, but we should be aware of these conditions. See the erythema, which is quite defined, and it is giving the shape of something that we should correlate it, and take the patient in a confidence and ask the history. Fellatio-associated erythema of a soft palate, an incidental finding during the routine dental evaluation, and ask the patient regarding the same history. Then coated tongue, we are quite likely to come across it, and this is often overlooked. And the patient has come for some different some of the other chief complaints. This tongue, what is the tongue? It provides a reservoir and a significant for the reservoir for pathogenic bacteria, and can contribute to the oral and systemic diseases. Effective management strategies, including mechanical cleaning, antimicrobial rinses, dietary adjustment, and addressing the underlying systemic conditions. It may be related to some of the systemic conditions also that one should take care of. Long-term studies also necessary to establish whether this coated tongue play a direct role in the onset and progression of a periodontal disease. Probably this is a research topic if some of the researchers are attending this lecture. Then periodontal abscess, although this is a bony condition, but still I'm including because it has got a soft tissue manifestations. Generally, it is present in the on the gums, a boil is present. And see, this is a case which has been reported. The periodontal abscess was reported due to the trauma, like the class 1 restoration was done, and the patient was having a constant trauma, and then the patient the growth was seen on the gums, and then if the radiograph showed there is a bone loss also, and then the patient has to be evaluated properly and treated further. Parolis is the condition that may present as a soft tissue overgrowth, and it is generally associated with a non-vital tooth. And probably all the time it has been associated with a once you give a digital pressure, it gives a pus, and then only the diagnosis of this thing is been made, and it can be associated with a non-vital tooth. Then this variety, recurrent herpes labialis, we may come common across with, and it has got a wide presentations, and it may be present at the angle, at the corner, upper lip, tongue, lower lip, everywhere it can be present. And some of these are the presentation, like involving the lower lip. It may be finding in the pre-sore condition like this, and some eruptions without irritations in the beginning, and probably after the irritations may start, then encrusting the open lesion, then there is a scab present, and all these things should be present when we are diagnosing it. It may have intraoral manifestations also, that is intraoral recurrent herpes labialis, that is quite common on palate and gingiva, that one should consider. A lesion caused by herpes simplex can occur in the corner of the mouth and can be mistaken as angular chilitis of another, which is another cause, and sometimes it is called as a angular herpes simplex. So if the lesion is present at the corner of the mouth, that can be called as an angular herpes simplex. A cold sore at the corner of the mouth behaves similarly to elsewhere on the lips. Rather than utilizing antifungal creams, angular herpes simplex is treated in the same way as a cold sore with a topical antiviral drugs. So that point has to be kept in the mind when diagnosing the recurrent herpes labialis. The treatment is, it's a self-limiting disease, but see, it's a self-limiting disease, but diagnosing and giving the treatment is important. And topical application, if needed, also antiviral anesthetics, and if needed, systemic antiviral drugs should be considered. Then angina bullosa hemorrhagica. It is a blood-filled blister that can present. Most common is on the buccal mucosa. It is associated with a trauma case. So it can have a small presentation as well as it can have a large presentation, like it is being shown like this. Like till the time we notice, sometimes it may fall up, and it just requires an identification, and it just requires identification of the condition, assure the patient the benign lesion of this condition, and you may proceed for the further treatment. Then chilitis glandularis. This is a rare entity. The case reported here was a 40 years female. She was having a persistent painful swelling, 2 months duration, which was having some dryness and itching since last 1 month. She has tried with some Ayurvedic medicine that didn't give any history. On examination, the patient had a diffuse erythematous swelling on over the lower lip that is not associated with scaling and ulcerations. No facial palsy and fissuring. That has to be ruled out for the condition called as orofacial granulomatosis. And once the do the thorough examination, other examination like diagnosing itself on seeing the case extraorally is not sufficient. See, any related lesions are present intraorally. The authors have done chest X-ray, Mantoux test to rule out the tuberculosis, which is quite commonly associated with such conditions. And they have done a food allergy test, which was positive for some allergens. And then they had taken a biopsy, which was seeing a non-causating epithelioid granuloma. The patient was asked to avoid the food allergens for which the patient was tested and came positive, and then was treated with 65 mg minocycline for 2 months and intralesional triamcinolone acetonide 10 mg per ml weekly, once 4 weeks following which there was a complete resolution as shown in the figure. This is a rare entity, chilitis glandularis, and the treatment is difficult. The present case reports reveals the importance of food allergy test and the role of food allergen in the pathogenesis of the diseases. Intraoral fibromas, these are the quite common conditions we can come across. It has been called as the irritational fibroma. It is associated with some irritation, and the irritations which are quite common is the lateral border of the tongue and the buccal mucosa. It has been involved. Some of this, it has been associated here, like the having a swelling, the growth on the gingiva, that was due to the some close bite, and the patient may have a small presentation like this to the large extent like this if it remains like this, because it remains the patient is not having a pain, so the patient may neglect it and it may go large size. So these are the fibromas. You are supposed to excise it, diagnose the nature of the disease, and then excise the fibroma, do the histopathological examination of it to confirm the nature, benign nature of the lesion. And most important is, once you excise it, the treatment is not over. You have to supposed to identify the irritation, what has caused it, and you are supposed to remove that irritation. So that thing should be kept in the mind once this condition called a fibroma comes to our notice. Pyogenic granuloma, it has been called, like it's a variant. These are some of the manifestations, and here there is a little rapid growth. Pyogenic granuloma may show little rapid growth, and because of that the patient may have a fear of a malignancy. The bleeding is more, the histopathological examination has to be done, recurrence is more, and the removal of the irritant and oral hygiene maintenance, all these things you are supposed to take care. See, the pyogenic granuloma, the word is a misnomer itself. Like, this lesion is not having a pus, but because of some constant irritations, it may have, see, can if we can see here, there is a white appearance of the lesion because of the constant bombarding of the upper molars on this lesion itself, and that has caused the irritation here, and this white appearance may mimic as a pus, so it is called as a pyogenic granuloma. But being a pyogenic granuloma, it is not a pus containing lesion. In fact, it is having a fear of a the more bleeding is present. These are some of the other presentations of the pyogenic granuloma. So it can go to this large size also. And the location also, actually most common location is the maxillary anterior gingiva, and it is quite common in the female too. See, if you can see, if we can see indentations of the teeth, that has given a white appearance. So it's not associated with a, so it is not associated with the pregnancy induced changes, because after delivery generally the lesion subsides if it is associated with the pregnancy related changes. So these are some of the manifestations, variations. Even some small lesions like this also present, but this is not a simple gingival inflammation. It's a growth occurring that is called as a pyogenic granuloma. Now we'll see this entity also. It is a peripheral and a central giant cell granuloma also. Peripheral giant cell granuloma is manifestation on the gum itself, and it may have the growth similar to that of a fibroma or pyogenic granuloma, but the histopathological variations are there. And this, what it shows, this entity only shows there is a cupping resorption. It is a giant cell lesion. Again, being a giant cell lesion, it has got a the recurrence rate is more in this case. And this peripheral or giant cell central giant cell granuloma needs to be considered for a brown tumor of a hyperparathyroidism. And this brown tumor of hyperparathyroidism is generally associated with central giant cell granuloma. The specimen is of a brown color, so it is called as a brown tumor. And the PTH levels are increased. We have to check that. We have to give take a physician's opinion regarding the same. This is a case report. Generally, it has got a central variety, but in rarities, it manifests on the peripheral giant cell granuloma also. Now, why we need to differentiate these lesions? Even we'll see this also. Oral capillary hemangioma mimicking pyogenic granuloma, a challenge for diagnosis and treatment. See, again, this is a capillary hemangioma, which has been seen as a pyogenic granuloma, what we had studied before. Now, the treatment probably remains the same, the excision, but diagnosing the condition before you go for excision, the treatment of a fibroma, pyogenic granuloma, or peripheral giant cell granuloma is excision that anybody will do. But diagnosing it, whether it is as a fibroma, whether it is as a pyogenic granuloma, and whether it is as a peripheral giant cell granuloma, is the skill. Because the pyogenic granuloma is likely to have a more bleeding. Again, it is likely to have a more recurrence rate as compared to the fibroma. Then then peripheral giant cell granuloma is a giant cell lesion. So just observe if it has got some cupping resorption and it is attacking the bone also, because you need to curate that bone also after doing the excision. So all these points should be kept in the mind before the excision has to be done. Like in case of a bleeding, like the patient may, once the patient is sitting in your dental clinic and you excise a lesion, and if it is a pyogenic granuloma, the the lesion may bleed, and the patient's relative who's watching may say that it has got a more bleeding than what I had done this thing. But who are going to tell you that your case was a fibroma, so it is less likely to bleed, and this case is a pyogenic granuloma, so it is more likely to bleed, and that the patient may have that fear. So all these things should be kept in the mind before we plan for any excision of such kind of lesions. Even this oral capillary hemangioma, which is mimicking the pyogenic granuloma. Now, this lesion, which has been diagnosed as a capillary hemangioma, probably it is not having any erythematous lesion. But in all such cases, we are supposed to have a suspicion regarding the same. So all the time, the care should be taken about the bleeding, and then the excision should be started. Now, this is a case of a capillary hemangioma, which is probably having a manifestation same as that of a pyogenic granuloma, what entity we had studied before also. Now, again, this is being a capillary hemangioma, it is more likely to bleed than the pyogenic granuloma. And again, we are supposed to take a care of this. So all these things should be kept in the mind. And even though clinically, before doing a biopsy, we have got some suspicion of a lesion, what it could be other lesion, that also should be kept in mind, and we should approach for the surgical excision of surgical excision should be done in that way. Then hemangioma, how the hemangioma looks out. Like this patient had turned to our department, and there is some elevation on the tongue. What made us suspicious of having it is a bluish component. Yeah. So we'll come to it afterwards. The diascopy. The lesion is pressed before it is diagnosed with a. But this chairside investigation you can carry out easily in your dental clinic setup and find out if the patient is of a vascular, the lesion is of a vascular origin. Okay. Now, again, this is a small case. This is a unusual presentation of hemangioma which has been occurred, and it has been treated in a different way. But this is again one of the presentation, and this is a hemangioma, not only a small growth. This has got a central component also that we should see if it has got some peripheral manifestations. So this case is been made for that. This is again one more case which was been reported to our department, and see the way it has been showing the manifestations. The patient here reported the large involvement, if you can make it out. See the video. Once the patient protrudes the tongue, the way the tongue is coming out and a pebbled appearance, you can make it out easily. The swelling is a little bit increasing, giving a history that the swelling is present since last 10 years, and probably is taking some injection. The nature of the injection is not aware. Taking the injection, the swelling little bit is not able see to put the tongue up. How it could be? See the swelling is having some lack of discoloration. Probably that will be a part of racial, yeah, racial pigmentation. The patient is having same kind of swelling on the lower lip, which is little, yeah, crossing the midline, and is involving the median border going on to the skin and inside of the they will. For us, the presentation is appearing like that of the lymphangioma, but hemangioma can be considered the differential diagnosis. So what is this? If needed, a radiological examination has to be done with suspicion. Even the aspirations may be dangerous in some cases, so that has to be carefully aspirated. And if at all the central lesions has to be aspirated, they should be approached from the periphery of the lesion. Hemangioma suspect vascular lesions nearly in all cases. Do the chairside investigations first and then proceed for your excision procedure. See, this is what a diascopy, we have discussed this. The press, use this glass slab, or even cover slip you can use. The plastic spatula, if it is there, that can be pressed on the lesion, and it's you have to check for the blanching of the lesion. Then this is another case which has been reported in a different way. Like if you can see there is some swelling is associated, but if you can notice there is no gingival inflammation, marked gingival inflammation has been not seen absolutely at all. Okay, so that made us a suspicion of diagnosing it in something different entity. And when this lesion was excised, and see the radiological examination has shown that it has got some diffuse involvement, and when the lesion was being excised, it turned out to be a large B cell lymphoma of the gingiva. Like all these presentations, these are the uncommon presentation. Like we should have a suspicion in the mind, like why the swelling has occurred, the swelling of the gingiva, the swelling over the gums, which is probably involving in the bone also, but there is no inflammation or any mucosal, noticeable mucosal changes associated with it. Now, This is a separate entity, gingival enlargement. I'll just have a broad outlook. Most commonly, it is occurring because of the irritations, the calculus and the pockets. We are aware of it. And just a quick review. It may occur due to some of the drugs, and we should take the history of the drugs with the patient which is having. And this is the edentulous area was the patient, but this may not be a classified as a gingival hyperplasia. It is a growth on the this thing, and this is a classical examples of a drug-induced gingival hyperplasia which has come across our department. Now, there's one more interesting case. See, the patient has reported with swelling in the palate, and this swelling in the this is swelling over the palate. It is mimicking that of the dental abscess, and but again, the suspicion. Why the suspicion was made? Because there is no obvious pathology present surrounding the lesion to give this appearance. So ultimately, the authors, the writers, just a minute, excuse me. The authors has done aspiration. Okay, the authors have done aspiration, and if it would have been a dental abscess, what it would have been a dental abscess, then there should have been a pus should have been come out through this, and the suspicion what the authors had made in the initial this thing. Uh, this is something different than the dental abscess, which is mimicking a dental abscess, but that turned out to be a mucoepidermoid carcinoma of the hard palate, which was mimicking that of the dental abscess. Then again, see, this is looking like a hemorrhagic lesion and a vascular lesion, but that turned out to be a mucocele on this thing, and the superficial location. The lesion was excised, and the histopathological examination is done. So all these lesions may have some varied presentation that we should keep it in the mind. See, this is a mucocele presentation, and the mechanism for the development of the mucoceles are two, that is mucus extravasation, generally regarded as a being of a traumatic origin, and mucus retention resulting from the obstruction of the duct or of a minor or a accessory salivary gland. Then this is an incidental finding of actinic chilitis, which is localized on the lower lobe. This is the authors have reported this case during COVID era, because the case was diagnosed by the help of a telemedicine. The patient was worried about what? The patient was worried about the chipped of ceramic, and the patient had given a call to a doctor that this has been occurred. And the doctor said, send the photo, and then we'll discuss what has to be done. Once the patient has sent photos were sent, then the doctor found out some lesions associated with the lower lip, and he has taken a proper history, and then the patient was called, and the biopsy was done, and then further treatment was initiated. Okay. Now again, this is a case of a exfoliative chilitis. What has happened? A 22-year male has come with a burning and peeling of the lips of the vermilion border of the lips, and edema, dryness, and slight desquamation. There was a contact chilitis, and the patient asked to change the toothpaste. No improvement. The moisturizer was given, and the moisturizer given a little improvement, but however, the burning symptoms persisted, and the biopsy also was non-specific. Then the patient was treated with the topical steroids with a psychiatric evaluation. See another case. The patient had some vesicles and whitish yellowish crust on the upper and the lower lip, and the evaluation of the lesion with white plaques on the lower lip also. Presence of desquamation, fissuring, and bleeding on the vermilion borders of the upper lip and the lower lip also. And the improvement of the clinical aspects of using topical steroids, and the lesions were showing the lesion showed improvement after a year and a follow-up by giving the topical corticosteroids. So again, this is one of the presentation of the exfoliative chilitis. See, again, this is a different case. 40-year female, some emotional problem, and thickening and cracking and peeling of the lower lip with more pronounced than the upper lip. And she had 7 to 8 year history of habitual lip biting, accompanied by a pain and a burning sensation that worsens with exposure to sun and cold. She was prescribed topical steroids, vitamin B12, and iron supplements for 8 weeks. While her symptoms subsided during the treatment, they recurred upon discontinuation of the medication, and further Ayurvedic treatment was been given to this patient to relieve the symptoms, and some results it has been shown. Now this is again a challenge to the new researchers, that Ayurveda has got some role in oral mucosal lesions, and complementary treatment that we generally called as a alternative and complementary treatment, that now the new researchers that they have to work on this issue and find out if they can find out some solution to the oral mucosal lesion with the help of a Ayurvedic treatment. Now, this is a multiple phleboliths. What has happened? 56-year female presented for a dental examination. The OPG, which was been revealed a multiple well-defined radio opaque lesions. Masses laminated approximately 6 to 8 diameter, located on the right side, superimposed on the coronoid process. Phleboliths in the maxillofacial area are mostly asymptomatic and could represent the presence of serious vascular anomaly. So we should keep it in mind, all these things. Dentists should be aware of these calcified bodies to avoid the risk of hemorrhage during the treatment. Now, these are some of the suspicious lesions which require a prompt biopsy. What has happened? The patient has presented to the dentist complaining of the pain, what experiencing on the left lateral border of the tongue, and more than 2 months. An oral examination showed the area of induration and firm palpation. Now, even though the lesion looks like of a benign and it doesn't show any malignant changes on this thing, we should go for a biopsy, because the site where it is occurring, it is suspicious and it is likely to be having a more malignant changes during the there are high chances that it will turn into malignancy in such lesions. So the care has to be taken, and in such cases the immediate biopsy has to be taken out. That's what we wanted to highlight. Now, another case, the patient noticed a thickened area at the midline of the lower lip, and she experienced a recurring crusting of the lip with a sensitivity for more than 5 years. The patient sought advice from the primary care physician. Examination of the lip confirmed the firm, elevated nature of the lesion, and the lower lip also showed the features of actinic changes. All these things, the proper history has to be taken out, and then we should go for a biopsy. See, again, this is a case. During a routine dental examination, a large area of asymptomatic leukoplakia was noted in a patient with 40 pack years smoking history, and the lesion was a homogeneous in color and texture. Even though it is looking like that, we should go for a biopsy in such cases. Another case, during a dental hygiene appointment, an area of the lower lip that presented as a white and fissured was noted. On questioning, the patient stated that he regularly placed smokeless tobacco in the area. Take a proper history, and according to the manifestation of the lesion, you should proceed for it. Erythroplakia, it's been, hardly some cases have been noted out, and there is a red velvety patch that is what been defined as, and that cannot be classified as any other entity. So all these cases, it has got some etiology, tobacco and alcohol consumption, suspect the diagnosis, and then go for a treatment. Biopsy first. Like this case also, most of the time, whatever the erythroplakia cases are the erythema, which has been treated as a erythroplakia, but it requires a correlation with the patient's habit also, and the biopsy has to be done. Generally, all the erythroplakia has got a well-defined margin that has to be find out, and then the treatment and the biopsy has to be first taken out, and then the treatment should be done. Now, some of these cases see the changes occurring on the ventral surface of the tongue, which generally we miss when doing our routine examination. This is a Ebbing-Tide appearance, which has been seen in the homogeneous leukoplakia. It is the changes are going towards like that, even though it is not classical, but changes are going to like that. And in this case, we can suspect this. This is a cracked mud appearance of the homogeneous leukoplakia. If we can notice here, that is a classical presentation of homogeneous leukoplakia, and take the history from the patient and try to correlate the appearance with the history of the habits of the patients. Now, again, this is a case where the white lesion is seen on the floor of the mouth, and it turned out to be, we have to take a biopsy in such cases, because again, this site is risky. So immediately we should go for a biopsy for such lesions. There is one more interesting case. The patient has presented with a swelling on the tongue, and after aspiration of the tongue swelling, the pus discharge, and it was been diagnosed as actinomycosis. Now, this condition, Desquamative gingivitis, which has been present in many of the diseases like benign mucus membrane pemphigoid, which has been the case reported here, and see the desquamation is been occurred, peeling of the gingiva. peeling of the gingiva, that is a desquamation that has been occurred, and we should able to correlate that it has got some different etiology than the local irritation, and it is present in the pemphigus, in erosive lichen planus also, that has to be ruled out. See, this is a case of a desquamative gingivitis, even though it was been associated with some local factors, but it is a case of a desquamative gingivitis. If you can see on the palate also, there's a erythema, which is a pronounced erythema, which has been present, and bands like presentation. And after treatment, it has given some, the changes have occurred once the, if you can compare this and this, some changes are being seen. If you can see some formation, reticular formation is also there here. So that made a diagnosis of desquamative gingivitis, and it is not a routine, it has been not caused because of the routine irritation. Okay. So this is a case which has been reported in our department, and the patient was having a diffuse erythema, and we treated with the steroids and the lesions. Probably it was an oral allergy, and the lesions vanished within 2 days of giving a topical application. And before we could diagnose it, it has vanished up. Now the case here, which has been reported as a strawberry gingivitis, and that has, from that itself, they have diagnosed the vaginal granulomatosis. So the unusual appearance of gingival hyperplasia, marked erythema, that should make a suspicion that it is not a common behavior of the tissues, and that's, you should we should able to correlate that it is having some different manifestation, and we should treat and do the investigation accordingly, like that. Now this is a HIV. We have got various manifestations, and some of these manifestations are being shown here, and we are all aware about all the conditions and the changes which are occurring. Oral candidiasis is a manifestation, and that is I mean, that can be seen in case of HIV patients. Now see, again a case here, gingival tuberculosis. See, again, just see the manifestation. It cannot be classified as a routine gingivitis, neither it is cannot be classified as a classical case of a gingival hyperplasia, as it is showing some overgrowth along with the irritation. There is a bleeding, plus there is some whitish area, slough has been formed. So we didn't do anything. We just go on doing this thing, investigations, and once the investigations were done, this case was to be turned out to be a gingival tuberculosis. So once, I mean, you see, once the case is been seen, it's been not seen as a normal this thing, normal gingival the gingival hyperplasia presentation. What generally we do get inflammatory or drug induced, or neither it has been caused because of irritations, because we cannot see that much of irritation to give, and this was that too, this was a child patient. Now this is again a case which was been traumatic ulcer, which was been manifested, ulcerative lesion, traumatic ulcer, which has been caused because of it was of a tuberculosis origin. Here, a case of oral tuberculosis, it was misdiagnosed as a denture hyperplasia, and again a plasma cell granuloma misdiagnosed as Epidus here. See that, I mean, we should always keep it in mind, all these entities, once we see any presentation in the oral cavity. Then again a case here, which has been here diagnosed as a tuberculosis gingivitis, and see the manifestation again, why the lower gingiva appears to be quite healthy rather, and how the manifestations have occurred. I mean, if it would have been occurred because of a poor oral hygiene, all the mouth, I mean the gums and the teeth, everywhere there should have been a part of inflammation and changes. But why it has been there in the upper this thing only, that we should make a suspicion, and then that suspicion itself should make us that it is something different than the normal, and we should do the investigations. So this was been after the treatment. So clinician need to remember that oral tuberculosis is possibility when the patient has a non-healing ulcer, especially because it is so rare. The diagnosis must be confirmed through biopsy, histopathology, or microbial culture, and acid-fast bacilli staining the specimen, or a tuberculous bacilli culture. Sputum culture is also required for the diagnosis. Patient at most risk are those who have defects in the oral mucosa caused by the chronic inflammation, trauma, or leukoplakia, poor hygiene, where pathogens can reside. Person who wear the denture should be checked regularly for proper fitting so that they do not create the conditions that can lead to the development of ulcerative diseases, including oral tuberculosis. Then, what is this? This again, candidiasis occurring, pseudomembranous variety, which is occurring on the palate and the dorsum of the tongue. Again, an uncommon lesion. This is a squamous cell carcinoma secondary to the lung metastasis, misdiagnosed as the denture irritation fibroma because the patient was wearing the artificial tooth there. But see the manifestation. The rarities, it can occur like this. Sorry, I mean, this is the case of the squamous cell carcinoma, which has been misdiagnosed. Sorry for this thing. And this the case, the first case which has been shown is a plasmablastic lymphoma, which has been misdiagnosed as a pyogenic granuloma. So these are the mucosal tags, which are the early manifestation of a gingivitis and the first manifestations of the Crohn's disease. This is what orofacial pain, and like my teacher used to say, this is the bread and butter of dentistry. Because of this, the patient comes to you, and because of this, the patient again don't see your face. So oral mucosal lesion can be a cause of this orofacial pain. So whatever the patient is having, the pain, we should treat this pain on a priority basis. Oral lichenoid reaction, here the case which has been reported, like 42-year male, which has been reported with a burning sensation for nearly 6 months and aggravating of the burning sensation on hot and spicy food and a drinking of the hot beverages, no habit of smoking or tobacco chewing. He was diagnosed with a vitiligo 6 months earlier. Before he suffered from a burning sensation in the mouth, he started using topical Unani medication on the lower lip, and probably the lesion has occurred. The lesion has given the presentation. These are some of the other presentations of oral lichenoid reactions. These are having the same manifestations that of the oral lichen planus. And it has to be distinguished from the oral lichen planus, which is typically bilateral, not having any drug allergy or having a relation with a like not present in the close contact with any restorations or any prosthesis. This oral lichen planus, the 9-year female we have treated, see how diffuse manifestations, and we need to start a steroid for this patient. And after steroids, the patient has shown some improvement. The diffuse presentations of oral lichen planus, they may present, they involve the tongue, how it has been involved. See, this is what is the presentation of a reticular lichen planus. This is what is a presentation of a plaque-like lichen planus. And this is the presentation of atrophic lichen planus. It is a symptomatic variety. And then the bullous lichen planus. Then solitary papillary lesions on the dorsum of the lung and ulcerative lichen planus. So all these are the presentations of the lichen planus that will come in our clinics. And this is again a challenge in oral medicine. And the new researchers have to work on this issue very seriously. There is no specific evidence that possible association between OLP and CVD association. We can provide one between OPL, that is, and CVD risk factors. Like this oral lichen planus may be associated with the CVD risk factors, but there is no yet now it has been not been correlated with the actual CVD. Now, especially those related to the lipid profile. More studies are needed in order to evaluate this relationship in patients with diagnosed CVD cases. Malignant transformation ranges from 0 to 37% with a mean range of 4.59%. The highest rate of malignancy was noted in the erythematous and erosive lesions. In this way, follow-up of OLP patient should be carried out more efficiently and appropriately. Now, this is a separate entity that needs attention. Probably sometimes it may have a similar presentation like that of a lichen planus, but the treatment may differ slightly. So chronic ulcerative stomatitis, we should be able to diagnose this. Now, these are some of the presentations of the chronic ulcerative stomatitis. See the maxillofacial gingiva exhibiting the prominent ulcerations, especially around the cervical areas of the anterior teeth. There are multiple ulcerations which are seen all over the mucosa. In the other case, extensive erythematous ulcerations on the right posterior buccal mucosa and vestibule noted clinically, and the ulcers were typically surrounded by extensive white areas, including prominent striations. So it is mimicking that of the lichen planus and desquamative gingivitis. But chronic ulcerative gingivitis is again exhibits a unique resistance to the treatment, standard treatment protocols. So it has got a special consideration. Like once the treatment fails, whatever the treatment we are giving, it fails. of the routine lichen planus cases, then we have to start with systemic corticosteroids and immunomodulatory medications. However, long-lasting favorable clinical response may be achieved with hydrochloroquine pharmacotherapy. During my PG life, I had come with a case of a chronic ulcerative stomatitis, and we have treated with this anti-malarial drugs, and then the results were achieved. Okay, these conditions you are likely to come across, and some of these are the presentation like erythematous. There is a ulcer which has been surrounded by a defined erythema or erythematous halo. See this case, if we can make out ulcer, linear ulcer like this patient has reported to me in the COVID era, and patient was suspecting the mucormycosis, which I need to explain the patient in detail that it is not a mucormycosis and it has got a different manifestations. This is a major of the ulcers, and this is what again symptomatic treatment and other modalities are available for this. It has been surrounded by a erythema, that is a diagnostic sign. See, now this is again a case of a traumatic ulcer. Now it is mimicking that of the malignancy, and we have to do biopsy because it may show some induration. And here, unless the biopsy is been confirmed, we are not supposed to go for a diagnosis and the treatment. This is what now again a challenge in the field of oral medicine, where again the young graduates are supposed to work on it. Oral submucous fibrosis, bilateral blanching, mouth opening reduced, we are knowing it. Tongue protrusion is been reduced, and there is an area of erythema, probably sometimes vesicle formation preceded, elliptical rima oris, and see all other presentations we are aware of. We have not come across the, I mean, come out about the authentic treatment modalities. We are trying for it, and we should work on it. Burning sensation, manage with topical anesthetics and steroids, give the intralesional injections, give physiotherapy. And on this entity, we are supposed to work, and the young researchers should take this as a challenge. Pemphigus, again, one of the important thing is chronic ulcerations. That is what is the manifestations. These are some of the presentations. Once the pemphigus case has come, see there is a diffuse involvement in a short time. That is what is probably made as a diagnosis. Find out the other lesions if there are present, like this case has been shown, the lesion on a scalp. And this is what is the erythema, or the involvement is so diffuse that before the patient comes, it involves all of the oral mucosal sites. See the tongue. And these are some of the presentations. The Nikolkis sign, which is supposed to do on skin, even we do on intraoral lesions, it will it shows positive. Take home message for the pemphigus: suspect pemphigus in all chronic ulcers. Ask for the skin ulcers, oral lesions first to appear and last to disappear, and starts the steroid immediately. Once you suspect it is of a chronic lesion, you should immediately start the this thing. Now, this is being a bony lesion. I have included in the oral mucosal lesion because this is one of the seniors. My senior had a case. See, it is looking like that of the gingival abscess here, but there was no carious lesion and nothing gingival inflammation was there. And we had taken a radiograph. If we can make out a well-defined cystic-like appearance here, and this, then after a biopsy, it turned out to be a odontogenic keratosis. So, I mean, what it will, I mean, the manifestations may vary from a unusual manifestations to the simple manifestations. So all these things we should have kept. Somebody would have just punctured this lesion and probably to see the treatment, but that is not the case. You do the proper investigation, take, if needed, do the aspiration, and then proceed for the treatment. So that is what I wanted to emphasize. Metastasis to the jaws, rare manifestations, but can do occur, and that too with a soft tissue swelling also. Generally, it involves the bony, I mean, it has got a bony component, but after sometimes it may have a soft tissue manifestations, and from we can learn out that it is having it is a metastasis to the jaws. This is a case which was being diagnosed as a renal carcinoma was diagnosed because of a tongue lesion. So necessary investigation has to be carried out. The persons who are working, especially in the hospitals, they are likely to come across with such cases, and suspicion should always be made with this. I mean, what I wanted to highlight is the lesion which has been present here. It has been not just limited to that particular area. It has got some systemic manifestation that we need to rule out. Now, this is a case which we had treated in our institute. Like this patient has come with manifestations and the candidiasis was suspected, and here we have given a ozone oil therapy for this, which is again a topic of research, and it has been the results were found quite satisfactory once the ozone oil treatment is been given. And this way we have done a study on this and we have presented in a paper also. Now see the manifestations, how small the lesions, and again it is not having the typical manifestations of malignancy, but on biopsy these turn out to be a squamous cell carcinoma. Again, these lesions need special attention, and we have to do investigations before it goes for a diagnosis. These are the cases of a candidiasis. Now, adverse drug reaction, the definition was put that it's an appreciably harmful or unpleasant reaction resulting uh, resulting from an intervention related to the topical use of a medicinal products which predicts hazard from a future administration and warrants prevention of a specific treatment or alterations of the dosage regimen or withdrawal of the product. The most frequently reported medication classes, this is a case, hyposalivation due to the polypharmacy. These may be because of antidepressants, antipsychotics, antihistaminics, and all these drugs which the patient may be taking for a long time. You should be able to diagnose it. These are the lichenoid reactions from rituximab, and how the lesions are occurring because like looking up that of the lichen planus dry, but it has been caused because of the lichen planus. The drug. The aphthous-like and the non-aphthous-like lesions. This is a sirlomas-induced lesion, again adverse drug reaction which has been noted in the oral cavity. So it has got a varied manifestation like that of the lichenoid reaction and aphthous regions. Now candidiasis, which has been treated by the topical steroid therapy here. Now this is again some of the adverse drug reaction caused because of various medications, and all these things we should able to relate with the procedure what it has been undertaken. Unusual presentation of oral malignant melanoma. This is present on the hard palate, and this can be present. I mean, this may have some unusual manifestation like this. Some systemic manifestations like diabetes, they may have a dryness associated with a parotid gland enlargement, and dryness of the mouth may be due to some action of a drug. Gingivitis, periodontitis, more severe and rapidly advancing with multiple periodontal abscess. Fungal infection, the dry oral mucosal surface favorable for the penetration of a candida albicans. As the tissue contains glucose, it causes lower tissue resistance, and the candida easily affects the tissue producing candidiasis. Pseudomembranous candidiasis, clinically the multiple curd-like white patches develop because of a precipitation of a tissue proteins. White patch is scrapable. On eliminating the area, the erythematous and the burning sensation is been left. So some of these are the manifestations: multiple abscesses and periodontal abscesses, candidiasis that can be seen. Anemic patient. Anemia is a condition characterized by the declined content of the hemoglobin and oxygen due to reduced number of a function of a red blood cells. Iron deficiency anemia is associated with atrophic glossitis, pale mucosa. The condition, also known as a magenta tongue, is characteristics of a pernicious anemia, which manifests the tongue in erythema and atrophy. An extremely reddened tongue with atrophic borders is usually preliminary sign of anemia. Angular chilitis, burning sensation of the tongue, lips, buccal mucosa are very common findings of this. So mucosal pallor and atrophy may be subtle and difficult to appreciate, but it can be an important indicator to find the anemia. Atrophic glossitis is more pronounced condition characterized by the bald patches on the tongue due to atrophy papillae. It may be associated with iron deficiency anemia, vitamin B complex deficiency. Atrophy can cause burning pain, tenderness, and erythema on the tongue. In addition to atrophic glossitis, candidiasis may also present, causing erythema, burning, and atrophy. Candidiasis can be a concurrent finding or an alternative cause of these symptoms. Angular chilitis may be manifested, and dyspnea, erythema, burning, and atrophy. The condition may be painful and uncomfortable. By recognizing these oral manifestations of anemia, healthcare can provide more comprehensive care and improve the patient's outcome. So turn yourself from a dental surgeon to oral physician. Treat the patient as a whole and not a cheap complaint of oral cavity. Pain control should be on a priority basis. Do not neglect the oral mucosal lesion. Do the proper imaging. Consider 3D imaging. Please pay attention to the tobacco habits and control. Emphasis on maintaining the oral health checkups, and be better excellence in the treatment, and the rewards will be long lasting. And this is again thanks to all, and thanks to the organizing committee for giving me this opportunity. Thank you.
Yes. Thank you. That was a very thorough presentation, a very extensive one. And I have one good news. We just crossed 6,000 subscribers on the channel. We were a
That's
little
great.
short of 6,000 and we just crossed it. So that was nice.
Okay, that's great.
Yes. And okay, now just reminding everyone, you can put in your questions in the chat. In the meanwhile, I'll just share some information. One is that this Friday, that is, today is Tuesday, so on Friday at 19:30 Indian Standard Time, we have a journal club with authors, which are interactive sessions where we make a presentation of a journal and then you get to discuss the paper and ask your questions with the author themselves. And this time the author is Dr. Lester Thompson. Of course, anyone would want to be able to question him, and it's an interesting topic too. It's head and neck myoepithelial neoplasms, the top 10 differentials. This should be something that is really interesting. I hope you will join us. And next is we have started the new session. This is the diagnostic table, slide 360. It's going to be there every 2 months. The first one is on the 6th of December. And we have set it up on our new website of our new academy. That is the but it is with extension, of course. It is the 360 Academy. So it is Oromed 360 Academy. And the website has the same name. I will put in the comments afterwards the link. What is interesting about it is we will be sharing the slides at least 10 days beforehand, so you can form your own diagnosis, so that it's not going to be just a blur of information. Another very interesting thing is we have a giveaway in this program. We have been donated a copy of the pathological basis of oral and maxillofacial diseases by Dr. S.R. Prabhu, who is the main editor of the book. And we will have a lucky draw during the event, and we will give away one copy of the book. That will be the print copy that we will send. So, that is the other interesting thing for you all. And of course, the International Oral Diseases Case Presentation, just reminding everyone this year's is going to be from the 8th to 10th of May. If you want information or to be connected with it, just scan the QR and get in touch with us. You can also find the details on our website. And yes, with that, now let's come back to questions. Have we got questions? So far, no questions. But I must say, I just noticed, I don't know what is the experience in other countries. And today we have people all the way from Ghana and, of course, South Africa with us. But at least in India, from when we were students, we have always been told that almost the entire population of India has to be considered as having been exposed to tuberculosis, and that anytime it can actually become active. So, this is something I don't know about your experience, but I'm not directly in practice anymore. But what I hear from doctors that I know is that the cases are actually on the rise. What has been
Yes.
your experience?
Yes, there are so many suspicious cases that can have a manifestation in tuberculosis. In fact, to tell you, during my PG life, I had a case of a parotid tuberculosis which was not having a systemic involvement, and it was a primary parotid tuberculosis. So, at least in India, we have to suspect, like whatever the manifestations are there, like granulomatous manifestations are there, and that time we must suspect tuberculosis in the Indian scenario, and that has to be looked as a suspicion, and a care should be taken to rule out tuberculosis has occurred or not, and according to that the treatment should be initialized. Like there are two three more cases with me which are out of this thing, cannot include in oral mucosal lesions. That's what I have not included in this. But the even the gingival tuberculosis can manifest as an this thing. I mean, gingivitis can manifest as a tuberculosis. So this suspicion of tuberculosis should be always there, and that should be ruled. I mean, it should be taken care of by proper investigation.
True, very true. I wonder if it is as much of a problem in other countries. Something to check. So we have a comment question from Professor Joss. I'm very impressed with your section on oral mucosal manifestations of TB, especially the gingival lesions. Do you think that these extensive lesions are blood-borne infections or secondary TB?
Uh, Most of the time this should be a secondary tuberculosis. That's what my opinion is. Whatever the cases or whatever the literature I had come across, and whatever the readings and experience which I am having, it should be a secondary tuberculosis. There are possibility of a bloodborne infections also, but even I mean, as I told you, that it should be ruled out, whether I mean, even it can have a primary manifestation also, like not having any systemic involvement. So even after doing the systemic investigations, the tuberculosis turns out, proper biopsy has to be taken out, and again it has to be ruled out for the findings, and then the treatment can has to be uh, the treatment has to be considered. The treatment plan has to be considered. Thanks for your comments, sir. Thank you very much.
Yes, in fact, I think when it is primary, it is even worse because you have no warning, and
Yeah,
sometimes
that's
it's
also.
just not there in the lungs, and that can be really, really confusing.
Yeah. And that too, I mean, it will, most of the time it will have a routine manifestations. Only slight suspicion, I mean, slight variation should make yourself diagnosing that it is going some way out of the routine tract. And the first thing in such cases, you should suspect tuberculosis.
Very true, especially in India.
Yeah,
Especially in India.
in Indian scenario at least. Yeah.
Yes. So, okay, we have Dr. Raut saying it was a great lecture, Abhay sir. Thank you for sharing your cases thoroughly. Okay.
Yeah. Thank you very much for the comments.
Then, okay, we have Dr. Priyanka saying, nice presentations. Are there other areas other than oral cavity which show fordyces granules?
Yeah. Nice question. Fordyces granule generally are seen bilaterally on the buccal mucosa, small amount, and probably sometimes having a diffuse amount, as I told in my presentation. And this Fordyces granules we used to look at as an routine normal variant, and now that should not be looked as a routine normal variant. And the Fordyces granules after buccal mucosa can generally be seen on the lower and upper and lower labial mucosa. In fact, we have seen such manifestations on the gums, but that we are not confirmed by the examination, histopathological examination. But this can be seen in the other areas also.
Very
Thank you.
nice.
Thank you for
Yes.
the comment.
Okay. And yes, we don't have any more questions, I think. So let me just share your certificate that also gives everyone still time, a few minutes to type away. So thank
Right.
you so much. That was a very nice presentation.
Mhm.
And yes, thank you for being here. And once again, to make the announcement for anyone who may have missed it, Dr. Abe was the winner of our faculty open mic. You all have seen the advertisements and the competition for going on for quite some time. He was the winner. And he is also going to be presenting a lecture in the conference. So you all should come to the conference to see that. Yes.
Thank you very much. Thanks for all giving me the opportunity, and I hope I'll be continuing in future also with you all, and connecting internationally, and probably I'll also learn from some of the international speakers and the way they are proceeding, the way are treating the oral mucosa, or whatever the researches they are taking out, we can take it on an Indian scenario also. And what is my suggestion, if some of the international this thing faculties are there, like we can have a combination of the research, that the same research will have in your country and probably at an Indian scenario, and with the same methodology when it is being done, probably we may have some different findings. That's what I wanted to tell. So that will have some benefit for the both the countries, and it will add the research value too.
True, true. So we got one more question in the intervening time. Dr. Pallavi is saying, oh, hi, Pallavi. Is she saying, should biopsy be done first or investigation to rule out TB in gingival lesions, as gingival lesions are very common? So when to worry?
Yeah. Actually, I told you, if you have got some suspicion, biopsy has to be done, basically. But if it has to be done first or not, I mean, if you can, if you are aware of the concept, chair side investigation, short investigations without any much more armamentarium, if you can carry out. Like if there is a swelling, if you find a swelling that generally seen intra-bony generally it is been, you can do the aspirate, find out if aspiration is something suspicious, then definitely go for the biopsy and then go for the excision. It's like that, even though the lesion is a small in size. Okay. And what is your question is not necessarily all the time, that will depend upon what. And the biopsy is has to be done, but I mean, before going for a biopsy, if you can do some chair cell investigation, then you basically plan for the going for a biopsy. That's what my suggestion is.
Okay.
And when to worry, that is a last this thing you had asked. Like as I told you, if you find little bit going something away from the normal presentation, think whatever possibilities you can think and then plan accordingly. As I told you, if even now hemangioma, if you are going, then how you can go for a biopsy? Like if it turn out to be hemangioma, you cannot go, the biopsy will be also fatal, so that will be also creating some problem. I mean, I remember a case which in front of me, it was been done as it, a periodontal abscess was done and that turned out to be hemangioma. So that should not happen. So all the care has to be taken, all the necessary clinical steps has to be followed out, do the palpation properly, try to locate if some lesion is showing some abnormality, and then plan for the further intervention.
Yeah, that was our last question. And yes, I think we can call it a evening. And
Yeah, still evening.
yes. So
Wonderful evening.
you
Thank you all participants.
yes. Thank you, everybody. Do you want to say anything before we just say bye?
No, nothing. Thank you all.
Closing
That's all.
remarks? Okay,
Yeah.
yes.
Bye
Okay.
bye.
Okay, everybody. See you all on Friday, hopefully. And yes, have a safe and a happy week till then. See you all. Bye bye.
Bye.
Thank you, Dr. Abhay.
Bye bye.